Hello everybody. Hello from Toronto. This is Arifa Muzaffar. Our website is www.eawaz.com. All these beautiful programs are there, and we are adding all the links so that for your convenience, if you can click any link, you can find the answers what you are looking for. In this show, I always have a wonderful person, Dr. Anthony Leeds, with me from UK. You can Google Dr. Anthony Leeds. What a wonderful person, great deal of experience. He was part of multidisciplinary team as well. Of course, graduated in England, and doctor also worked on placental transmission of malaria. That's in Niagara. Doctor, do correct me if I'm wrong. He was the chairman of Royal Society of Medicine Forum on Food and Health. Dr. Anthony is working on obesity, on formula foods. We did talk about on obesity and all the problems linked to obesity. Dr. Anthony, I welcome to your show, and how are you?
I'm fine, thank you very much. Thank you. And you?
I am always happy, healthy, and I think this word means a lot to me, because there are times ups and downs in the life, and when I say I feel happy, I feel healthy, and I feel terrific, that definitely changes my mood. Today our topic is we are going to talk about how much weight needs to be lost for the health benefit to be gained, and how best to get help. Dr. Anthony, now we need your advice.
Thank you very much. Well, I thought that today we might consider what's actually been happening over the last 20 or 30 years, during which time people in most parts of the world have actually gained weight. Certainly in North America, in Europe, in Australasia, and indeed in Southeast Asia and South Asia, we know that quite a proportion of the population have slowly drifted up in terms of weight gain. And surveys of populations have shown, for example, in North America, that on average people gain about 0.6 to 1.7 pounds per year. And if you imagine that happening over a period of 10 or 15 or 20 years, you can see that some individuals may well have gained 20 or 30 pounds during that time. And of course, there are consequences to that weight gain. We've already discussed a number of conditions that are associated with being heavy. There are the metabolic problems of diabetes and high blood pressure, and then there are the mechanical problems like osteoarthritis, and I suppose one could say that gallstones are a mixture of being a mechanical and a metabolic problem. But also, of course, we now know that in relation to the metabolic issues, there are problems relating to inflammation, and that individuals who are heavy usually have slightly more inflammation in the body, and as a consequence this drives a number of the conditions that are associated with obesity. For example, it does drive the osteoarthritis. There is an inflammatory element in the joints, and then this also drives the vascular disease, because there is an association between being heavy and also the risk of developing arterial disease, heart attack, and so on.
Dr. Leeds, as you mentioned, that if we look at around the globe, people are more obese, have more weight on, and I think it's a lifestyle. I need your suggestion on that and your point of view on that. It's a lifestyle, plus lots of energy drinks are available, lots of drinks and foods, added sugar foods are available. Does that, the governments cannot control it?
Well, what governments decide to do, of course, is very complex, because there are many factors that determine the decisions that are made. What we do know, of course, is that genetic factors play an important part, but also it's the interaction between those genetic factors and those predispositions, if you like, that interact with the environment. And there's absolutely no doubt, and there must hardly be a single person on the planet who wouldn't argue that there have been some major changes in lifestyle over the last 30 years or so. Many of these, of course, relate to technological advances with the availability of lighting throughout the 24-hour period. Of course, we perhaps don't get as much sleep as we should, and we've discussed that before, but also devices, computers, televisions, laptops, iPads, and so on, all of which tend to draw our attention and therefore make us physically inactive at the time. Of course, the more recent developments incorporate often some devices that encourage us to be wary of the inactivity and to correct it. And some of those monitoring devices that can be worn on the wrist do that. So there's a recognition, I think, among the companies who develop technology that there is a need for providing this feedback. So that's all good. However, in the meantime, what we've got is a population that has gained overall on average, and we also have to recognize that there are subgroups within the population. Some have gained more weight than others for a variety of reasons, but nevertheless, as a whole, the global population has become more overweight and more obese. And so then when we come to the question of, well, what are we going to do about it? Obviously there's a broad distribution of the amount of weight that people have gained, from just a few pounds to being perhaps 20 pounds overweight or 30 pounds overweight. And we also know, and we have some reasonably good statistics on this from some countries, not from all, that right up at the upper end of the distribution, we've got a rather greater increase in the number of people who are particularly heavy and who have super obesity and what we might call super obesity. And I think I mentioned that in the bariatric surgical service within which I worked a few years ago, we actually saw individuals who might weigh 200 kilograms, 400 pounds, or even heavier, although the majority would perhaps be maybe around, say, 160 kilograms to 200 kilograms. And those individuals, of course, were very often needing surgical treatment.
Understand, and of course we will talk about the surgical problems. Dr. Anthony Leeds, you will suggest what is required in a medical way, but as a layman in the community, I think income disparity has played a very important role, because those who have less income, here in Canada there are so many kids, they go to schools without breakfast. Another thing is those who have less income, just to fill up their trolleys, just to fill up their appetite, or just to when they go for the shopping, they don't do shopping wisely, because they have to do that much shopping in a given budget. They end up buying lots of sweet things, lots of candies, lots of drinks heavily loaded with sugar. And then of course mental health is also a big issue. Then people just avoiding to meet others, sit home, and they eat that thing. As a layman, in my opinion, that is also a big contributor towards the weight gain. Now, internationally, if we look at it, what are the consequences of this global rise in obesity?
The consequences are that the conditions that are linked to being overweight and obesity are also rising. And again, we've already discussed the rising prevalence of diabetes, type 2 diabetes, where we have individuals who are known to have diabetes, but also those who have diabetes but don't know about it, and then also those who are slowly drifting towards diabetes as they age, and who have prediabetes. Now, the actual numbers globally who fall into those categories of people who are undiagnosed or have prediabetes are very large indeed. So I think there's general recognition that much more needs to be done to help to identify these individuals, and in some countries this is being done very well. But also, of course, we're not just dealing with diabetes, but another example would be, as we've also discussed before, with an aging, heavier population, we're seeing more individuals with osteoarthritis. Most countries that are able to provide the service are seeing a greater number of individuals who need to have knee replacements and hip replacements and therapy of different types, medications and so on, for other joints that are affected by osteoarthritis. And there's no doubt at all that the epidemiological evidence shows that there is a relationship between body weight and the risk of developing osteoarthritis. And of course, we've also discussed the way in which reducing weight can be beneficial, both in diabetes and also in osteoarthritis. But of course, the list doesn't end there, because we also have unfortunately, the link between obesity and some cancers. It's very clear. We understand some of the mechanisms. And although it's more difficult to undertake experimental prospective work in this area, what we can do is look at risk factors. And we can show, many people have done the basic work showing that risk factors for cancer can be beneficially changed by losing weight. So there are a lot of areas, and indeed many of the chronic diseases that we are affected by are in some way linked to weight, in some way overweight and obesity.
Thank you very much. Now, which of these conditions what you mentioned are the most serious challenges?
I think that for any one individual, the conditions that challenge them most are the ones from which they suffer. But we also have to remember that individuals often are seen by us in the clinics with a combination of factors. So a high proportion of the older people with diabetes would have a bit of arthritis. They might have some obstructive sleep apnea, which we discussed last week, and we haven't yet had a talk about liver problems that relate to obesity. They may well have those. So by the time they get to a specialist clinic, such as the one that I was involved in, you might well find an individual who has several different conditions. They are in effect rather complex cases who do need specialist care. And again also, and I think you referred to this previously, I do believe that we need many more specialists, specialist physicians, specialist dietitians, specialist physiotherapists even, who have experience of helping heavy people to be managed in a way that reduces their weight and improves the obesity-related conditions.
Thank you very much. My next question is how to address these problems. We need the solution.
Yeah. So the interesting question here is how much weight loss is needed, or how many other changes in the diet and lifestyle are needed in order to help an individual to improve their health state. Now, of course, it varies enormously from individual to individual, and I will say again, as I always do, that every comment made in this conversation is, of course, a general one, and each individual should seek individual advice from his own physician, dietitian, and other specialist, where it's appropriate to do so. So we then look at a spectrum of need for weight loss from a very relatively small amount of a few kilograms or a few pounds, maybe 5 or 10 pounds, right the way through to the other end of the range where the bariatric surgeon is able to operate on an individual, and then subsequently the weight change may be really rather large. It can be 40 kilograms, it can be 80 kilograms, it could be 100 kilograms. Very variable. On average, in the big studies from Sweden, suggest around about 30 to 40 kilograms. That would be lost. Perhaps it would take 2 years to get to the lowest value, and then there might be a very slight drift up afterwards. But then we have to ask the question, how much weight is needed to achieve given effects? Now, the American Endocrinology Society has produced a paper which suggests targets that might be needed for the majority of heavy people. It was very interesting to note that the figure of 10% or about 10 kilograms weight loss commonly featured there to get good results in blood pressure reduction, 5 to 10 kilograms, to get good results for osteoarthritis. We're thinking in terms of about 7.5 kilograms, about sort of 15 pounds, in order to get a good reduction of pain. In diabetes, we know from the diabetes remission trials that the very best results produced most recently by the direct trial that's been run in the UK in Glasgow and Newcastle, aiming to get 15 kilograms weight loss. That would be around about 30 pounds. Is the target. Now that's actually quite difficult to do. So we then have to say to ourselves, well, how are we going to do this? We know that bariatric surgery can give those larger weight losses needed for diabetes remission. But we know also that conventional diet, which is a diet where the dietitian would discuss with the individual the type of their eating and the food intake, and then make a recommendation for a 500 to 600 calorie reduction on a daily basis. And then you would get a reasonable weight loss of perhaps about 0.5 kilograms or 1 pound per week. Whether that's an appropriate intervention or whether we need something else to achieve 15 kilograms, 30 pounds weight loss. Now, while there are individuals who can use conventional diet to achieve a 15 kilogram weight loss, we know they can do it. I've seen individual patients do it. It's usually where there is scope for change and where also the individual is relatively disciplined in being able to sustain the changes that are needed, and then also is not particularly challenged by the inevitable things that happen to all of us on a day-to-day basis. You know, there might be a stressful task that one has to do at work, or there are life stresses, death in the family, or serious illness, and so on. All those things that throw people off track when they're trying to lose and maintain weight. So individuals who are more resistant perhaps to those influences may well be more successful. So it is possible with conventional diet. However, when we look at the clinical trials, and I would remind everybody that the critical thing in making a judgment about what is appropriate to use within conventional orthodox medicine for achieving weight loss, we should of course always practice evidence-based medicine, and we should have good standard clinical trials to support what we do. So we then move on to the next step, which is the formula diet programs that have been of interest to me over the last 15 to 20 years, and which have been the subject of the diabetes remission trials recently. So the so-called direct trial, which has shown that achieving that 15 kilogram or 30-pound weight loss enabled 70 to 80% of the individuals to move into diabetes remission in the first year, and the majority of those to maintain that at the end of the second year as well. And then, of course, the bariatric surgical procedures are particularly helpful for those who have metabolic disease or perhaps would not be expected for a whole variety of reasons to respond to conventional diet. Bariatric surgery may well be beneficial. And then I think the final thing I should say is that we shouldn't just say, well, it's one thing or the other. Very often we might combine these, and we have to bear in mind that if somebody has lost 15 kilograms with a formula diet program, that's an 800-calorie diet run for 12 to 20 weeks in the Glasgow-Newcastle study, which might seem very challenging, but they were able to do it. After they've done that, of course, conventional food is reintroduced and they move into a maintenance program. And one of the criticisms that people often level against rapid weight loss techniques is that, well, people can't maintain those weight losses, can they? They'll always regain the weight. The evidence is that if they're properly managed and a proper maintenance program is made available, maintenance is possible. However, you have to have that maintenance program, the education that is needed to help the individual to be prepared for weight maintenance. You have to have that put in place during the course of the weight loss, and then also you have to support them afterwards. If you just leave them on their own, many people will ultimately regain the weight. But if you provide the appropriate interventions, you can get maintenance. For example, in Copenhagen, in the Arthritis Institute, we've shown that people with osteoarthritis can lose about 12% of their body weight and can maintain about 10% for 4 years if the right things are done. So we have got some good experimental evidence that we can now do that effectively.
Thank you very much. This is what I understood, that to develop a discipline in someone's life definitely can help a lot. Discipline in a way, what they have to eat, what they have to leave. But these days, Dr. Leeds, even if you eat ketchup, use ketchup, it has high content of sugar. We eat bread, it does have sugar. Anything what we eat, it has sugar in it, and of course that contributes towards weight gain. Yeah. My question over here is, in common language and common life, people sometimes say leaving white things, that is sugar and salt, avoiding sugar and salt, too much use of sugar and salt, that helps, and drinking lots of water, that also help to an individual to lose weight. Is that right?
I think that within those statements there is a lot of truth. So with regard to salt, there's the association with high blood pressure, and many manufacturers have reformulated their products to reduce the amount of salt. With regard to sugar, much the same has happened across North America, Europe and Australia and so on, and indeed in Asia, that some products have been reformulated to reduce the amount of sugar and salt. So that's working in the right direction. I think there's one other key thing that is important also, and that is that the amounts of foods that are consumed are critical. And I think when we began our conversations a few weeks ago, I said that there was very clear evidence that portion sizes have increased in size recently over the last 20 or 30 years, but in fact also over a very long period of time. So, for example, wine glasses, a very nice study showing the increase in size in wine glasses from the middle of the 18th century right through to the present time, but with the greatest increase taking place in the last 20 or 30 years. And when you look at plate size, dining plate size, that has also increased. If you look at the portion sizes delivered by some fast food outlets in terms of the amount of French fries and the actual size of the burger, those have gone up in the last 20 years, until very recently when many of the manufacturers and suppliers have actually recognized the need to moderate the portion size. However, perhaps I could just tell you one story, and that is that I did once have a patient who was also a senior chef in one of the tourist destinations in London, and we had a discussion about the issue of trying to offer smaller portions to people coming into the restaurant. And an interesting comment she made was that when people were offered smaller portions, they were then complaining that they were not getting very much for what they were having to pay for, because I suppose everybody has got used to receiving a certain amount of food for the amount of money that they pay. And so I think that then also underlines the need for education and in some way making the smaller portions more attractive. And I think also, to be fair to manufacturers, we've begun to see a reduction in the size of some portions. So, for example, in Britain, the consumption of chocolate increased, I think it was something like 50-fold over a period of 20 or 30 years. Portion sizes have gone up. The sizes of bars sold in supermarkets and retail outlets had increased. But I think there is a slight trend now to recognizing that at least a proportion of the population would actually like to buy smaller bars of chocolate and are doing so. However, there's always a price issue, isn't there? It's always the larger, higher energy content ones that tend to be less expensive.
Thank you very much, Doctor. Now, on an individual level, how can an individual help themselves not to gain weight?
Well, surveys that have been done
show... Or if they gain weight, how to lose it?
Yes. I think we have to start really by looking at how do you lose weight, because so many people have already gained more weight than should be the case. About 2/3 of the populations in North America, Northern Europe, and parts of Asia are heavier than is desirable. And so surveys have been done that show where people get their information from, and obviously information is passed by word of mouth. Recommendations are made about diets. People buy books, they buy magazines, they listen to television programs, and they follow that type of diet. Sometimes they seek professional advice. They might have a word with the doctor or the practice nurse. They might be referred by the doctor to the practice nurse for guidance, or they may be referred to the dietitian and receive appropriate guidance. One of the things I would have to say is that I think it's probably true that globally, whereas specialities like cardiology and endocrinology are recognized, and many specialist hospitals will have departments of cardiology and endocrinology, they may well not actually have what I would call a bariatric medicine department. And also in big primary care practices, there may not be a group that's particularly specialized in helping people to lose weight. I think that globally we have probably failed to allow the specialization into managing weight, and that is what is actually needed. So in parallel with giving the public the appropriate guidance, which is to choose the appropriate diets, they have to make the lifestyle and the dietary changes. Where they get their information from, of course, is their own choice, but that at some point they may well need to seek professional guidance. And the first point, of course, is to go and talk to the family physician.
Thank you very much. Is there any hormone in our body which stimulates to eat more?
Yes, essentially. And from the evidence we have, These vary from person to person. They may be more active in some individuals than others. And very interestingly, my colleagues in Glasgow who've been undertaking the work related to diabetes remission have shown that there is a relationship between the baseline levels of some of those hormones and whether or not the individual struggles to maintain weight or manages to maintain weight when they've actually achieved it. So in that trial, they used a formula diet program of 800 calories to achieve the initial weight loss. Then they were gradually moved back onto a conventional diet. And then, of course, they were observed for 1 year and then 2 years. And the individuals who were able to maintain the weight loss very tightly were slightly different compared to those who struggled to maintain the weight, and the hormone signaling was slightly different. And what this does is to highlight the fact that maybe in a few years' time we will be able to screen people, perhaps a blood test, and find out which individuals are likely to struggle more, and maybe we give them more help, or even, and we have to recognize that there will be a place for pharmaceutical products, and that pharmaceutical products that mimic the actions of hormones are already in place. And we've recently seen some published evidence that one of those in particular is very potent and can be used in some individuals. Exactly who, we'll have to wait and see. But we do now know that individuals do vary. So when people say, and we've all heard individuals say, well, I can lose weight, but then I gradually drifts back up over a period of time, we know that they're simply being driven by their internal physiology interacting with the external environment.
Thank you very much. And you know what, I just think about, we all try to take care of our external figures, our face and everything. Stomach is a beautiful organ. It's such a beautiful shape, and once we start eating more, I think it becomes T-shaped. It becomes just a bag holding stuff. In my next episode, I'll ask, is that right, doctor?
They vary enormously in shape and size, but they also vary enormously in the way they function and the way in which one of the hormones is released from them. But they also respond to how they, like every other organ in the body, respond to how they're treated. So the diet that is provided, and the dietary pattern, and we've spoken also in the past about dietary timing, and there is evidence that if you don't eat after, say, 6 or 7 in the evening, you're less likely to snack later on. But it all requires discipline, of course. But many of these manipulations relating to time are useful. Manipulations relating to the dietary content, we spoke earlier on about the macronutrients in the diet, the fat, protein and carbohydrate, and the dietary fiber, which can bulk out the diet, so dilute the energy. And we're hoping to be able to discuss some of those things in a later discussion.
Inshallah, God willing. So, where can our viewers get all this information? Just a quick tip.
Well, yes, thank you. As I've already mentioned, there are some extremely good sources in Canada, and at the end of the program, we'll be putting up some web links through to, for example, Obesity Canada, which has some really first-rate information, and we can also put up some web links relating to diabetes and osteoarthritis. So there will be two pages of web links at the end of this program.
Thank you very much, Dr. Anthony Leeds. I thank you very much for your time. And what I concluded is that we got to be disciplined if we want to lose weight. We got to be very watchful what we eat and what we should not eat. And we got to be very selective in the food choices. Of course, if we want to lose weight, we should have persistence, and everybody should have a weighing machine at home. After all the effort, how much are you going to lose? Thank you very kindly for watching it, and thank you, Dr. Anthony Leeds. God bless. See you in the next episode. Till that time, Allah Hafiz.